All right, good evening, everyone. Sorry for the delay, but we're really excited to have you tonight. So my name is Jen Widmeyer. I'm the marketing manager for PROstep, and Happy New Year. This is our first PROstep refresher course of the year. I'm thrilled to be here with Dr. Mesnier. This will be recorded, so at another time, you can go ahead and rewatch it or share it with your peers as well. And I'm going to pass it over to Dr. Mesnier.
Hi, everyone. Thank you. Thank you, Jen. Very excited. I'm excited to share minimally invasive surgery with you guys. I'm an orthopedic surgeon. I practice in Portland, Oregon. And my disclaimer is that I am a consultant for Stryker, but this is about minimally invasive surgery and my journey getting there and through it. And so I hope it's helpful. So if any of you guys have seen me present before, or if I've taught any of you guys before, you probably have heard this story. I first heard about minimally invasive bunion correction around 2011. I'm a Myerson Fellow, and I was at his Fellows Conference when a guy from England, Anthony Pereira, was showing slides about correcting bunions through a minimally invasive technique. I should be ashamed to say that I was in the back just closing charts and not really watching too much, but I was. And I looked up because I was intrigued for a minute. And then I looked back down like a total fad, continued working, didn't pay much attention. And then 2 years later, went back and he's there again presenting. And I looked up again, closing charts, and thought, gosh, why hasn't this been debunked? Why are we still talking about this? And paid it a little bit more attention and then kind of put it out of my brain. And I didn't go the following year, but during that time, from that conference to the next, I decided, I really just didn't really want to do bunion surgery anymore. Just all of the issues with bunions, we all know it. A lot of swelling, a lot of scarring, a lot of pain. And I was in a frame of mind where I thought, gosh, I think I just want to focus on the hind foot. And so I was in that frame of mind when I was there, and I believe it was 2017, and he was there again presenting, and he was kind of showing all these slides and talking about minimally invasive surgery for bunion correction. And I thought, you know what, Natalie, for all the reasons you want to not do this anymore, he's telling you, this surgery can mitigate a lot of that. And so I'm like, you know what? Why not? So is it fad or is it really the future? So I, decided that after tons of x-rays, patients like this, right? This is a typical approach to bunion correction. And I think we've all seen that with the lapidus. And then this was an open chevron osteotomy. And looking at the hard truths with bunion surgery, right? A lot of swelling, so patients had a lot of pain, and patients also required a lot of pain medication to deal with it. Scarring, right? The skin, the nerves, the joints, tendons, the subcutaneous tissues, and all of this caused tightness and neuritis, stiffness, and decreased motion of the joint. Swelling, we tell patients it can last for up to a year, and for a lot of bunions, it kind of got close to that, right? Which really delayed patients' return to regular shoes. And, recurrence is always possible, and that kind of sucks. But the other truth was that this second toe, the bane of the foot, and I was determined to learn to do second toe surgery a little bit better. So I kind of was facing these hard truths. And then he started showing pictures where, look, you can have this type of incision as opposed to the one we saw earlier. And at that point, I'm like, I really kind of only have one question, like, why not? Why not learn to do it like this? And so he got off stage. I'm like, okay, where do I go? And he said, Barcelona. And so Madrid. And so I made my way over to Madrid and did a little bit of sightseeing. And there's where I learned how to perform minimally invasive surgery for bunion and other forefoot deformities. And so for a brief overview, for those of you guys who have never seen this before, this is the power control unit. What makes it possible is that this box allows one to cut bone using low RPM but high torque. And that high torque initiates cutting of the bone. That is what really makes it possible. These are the instruments, right? We have cutting burrs, 2 by 8 millimeters for hammer toes, 2 by 12 for Aikens and metatarsal osteotomies, distal metatarsal osteotomies, that is. 2 by 20 for the chevron. They're wedge burrs to help remove bone, larger cutting burrs for the calcaneus. And I learned about all of these tools that can help you to create a little working space so that you can use these burrs safely and to have just a more refined working space. And while there, right, I came across this whole idea of correcting your bunion deformity via an extra articular approach to the joints, technically by moving it, but extra articular exposure to the deformity. And so with this, we're able to make small incisions, right? And with that, there's reduced risk of infections with these smaller incisions, earlier return to function, higher patient satisfaction, better cosmesis. And they're telling me all of this. And after doing the course and realizing that I wanted to move forward, I actually changed my practice. So here are the 4 steps, right? This is the first chevron. There's simple steps, but we'll go through it. You usually start by placing a proximal wire. You're going to make your osteotomy. You're then going to displace your osteotomy, and you're going to do your fixation. And so in that regard, it's not much different than an open procedure. So, I know I changed my practice, right? And the question is, should you? And these were questions I asked myself. Okay, it's a leap, right? Is it a bridge too far? Can that much displacement, just cause a fair amount of chest pain? And I realized that yes, it can cause a little bit of chest pain your first, but it's not a leap too far, and it is not a bridge too far. And so again, I ended up changing my practice. And so in December of 2017, I began, but not with a bunion. My first patient was actually a 56-year-old female with forefoot overload and metatarsalgia. She didn't have that much gastrocnemius tightness to really for that to be the sole reason for her forefoot overload. She had a broad-based callus under her forefoot, painful, lesser MTP joints to palpation, with some flexible deformities at her PIP joints. And so she knew I was going to learn this technique and was 100% willing to have me perform this in a minimally invasive way, because she had surgery on her opposite side and had developed a lot of scar tissue and a lot of stiffness. And so I proceeded, therefore, with performing the distal metatarsal metaphyseal osteotomies, or DMMOs. And we can see from the x-rays here, it's not that she had a dramatically long second, third metatarsal, but there was a little bit of length relative to the first. And that third x-ray there shows my starting point for my osteotomy. Again, not dramatically long, no joint subluxation, but she was painful. And so with the osteotomies, my goal was to elevate the metatarsal head slightly and to move them more proximally to minimize that overload. And we can see on x-rays here that the metatarsal, the second, third, and fourth are indeed shorter. And so I think that I achieved what I wanted to achieve by that minimally invasive approach. And so this again was my first case. We can see I did do something at her PIP joints, but we can see at the level of the metatarsals, just 1-stitch incisions, and we're all standing around and almost in awe, like, my goodness, we don't have these huge incisions. And being very excited by that, I then actually did my first bunion, which was later in December of 2017. So this patient had not a severe bunion, and I felt that somehow it was safer for me to start with a bunion that was not that severe. But she had clinical impingement. She had a lot of neuritis where her dorsomedial nerve just sort of irritated over the medial eminence. But admittedly, it's not as though it's a severe bunion. Again, I felt safer doing that. And she also had a prior bunion on the opposite side where she had a little bit of scar and some recurrence. And so she too was one of those patients that waited for months for me to actually learn this. And she was my first bunion patient. So now we're kind of off to the races, as I say. Let's kind of go into the cutting maneuver for a minute, right? So when you're doing your osteotomy, that bone is cut by rotating your hand and rotating the handpiece, not by lifting or pushing the handpiece up or down. So this, when I learned it, was taught as somewhat of a chevron osteotomy. And so you're going to enter the bone somewhat dorsal of center, and you're doing a bone cut dorsal and a bone cut on the plantar limb. And so you do that bone cut by rotation with the skin as a fulcrum, dorsal, and then in that same plane, then plantar, and you do a little bit of supination or pronation, depending on what side you're on, and to get that chevron cut. But again, low RPM, high torque, cutting the bone without cutting the tendon. And so getting my motion down, we can see here, I slowed this down a little bit so that you could see that, one of the benefits of this also is that you can have constant irrigation in addition to the low RPM, really resulting in less soft tissue damage. And then that irrigation, meaning that you're cooling that burr. But I think I went out of plane here a little bit, but I wanted to show somewhat in slow motion that I'm rotating my hand to perform that osteotomy, and that fulcrum is at the level of the skin. We're not pulling up, we're not pushing down. And I still have at that point, essentially a 2mm incision to accommodate that burr. And so in this, right now I'm creating that plantar limb, and we can see that I'm actually cutting by raising my hand, and it's not large enough to see a little bit of the pronation that I'm performing, but that incision is not widening, it's staying 2mm. I'm pivoting into to some degree from that point on the skin. And so the osteotomy is performed. Okay. And then you have that translation. This is just pictured the tool for translation. And I wanted to show this X-ray here because I'm going to come back to it to show you what I felt I did wrong with this first fixation. And again, this was my first bunion. So here we are. These are her X-rays. So the osteotomy is performed, and here are the guide pins. And what I want you to pay attention to is look on the X-ray on the left, on my left, where the guide pins enter the proximal metatarsal, and I felt fairly confident that I was proximal enough. And then I placed the screws, and look at where that screw head is sitting in that metatarsal shaft. It is much more distal than I expected. And then I did that second throw, and we can critique that in a second. But this was the fixation from that first case. This is what she looked like clinically immediately on the OR table, and I was excited enough by this to feel good about what I'd done thus far. This is that same patient, 12 days postoperatively. And yes, a little bit of swelling, right? But what I would tell you is that at 12 days post-op, she was no longer on pain medication. In fact, this patient took pain medication just through the weekend and was on Tylenol thereafter. And she was reporting a minimal amount of pain. So at 12 days, I took out the stitches, and that's the picture on the right. And notice again, her swelling is not that bad. She does not have a long scar. She does not have a massive scar. And she was really quite happy. And I was happy with the way it looked. And again, my first foray. So let's critique. So we have the good. And the good is that I think we have good joint congruency. Judging on and I judged that congruency on the lateral aspect of the first MTP joint. I think that the sagittal plane alignment is also good if you look at the lateral view. What I thought I could have done a better job on was the screw entry, which I thought was too distal, and also the screws are converging, right? It ended up not being a big deal in her because as much as I changed it to going to a minimally invasive technique, I actually did not change my postoperative protocol. And so my patients still were still off of it at this point in time. And we'll kind of talk about my transition for my protocol. So in reviewing what screw placement I think should be in order to get patients almost immediately weight bearing, on that AP view, you really do want to enter into that proximal medial flare of that first metatarsal. And we can see that right in here. And this entry point, exiting then the lateral cortex into the web space and then capturing that metatarsal head really gives this construct a lot of strength. And this has allowed for a lot of early weight bearing after this osteotomy. Again, it's really important, I think, with this technique to ensure that you're going through, two cortices and then capturing that metatarsal head. The exit for it is usually about a centimeter proximal to that osteotomy site. Okay, and so looking back at where one should enter, you can see that where I entered, and I outlined my metatarsal just for me to kind of visualize internally what I was seeing externally. That entry point is actually distal to the proximal first metatarsal at the TMT joint at the level of the skin. And so I really can't be surprised looking back that that screw was this distal. Okay, and we'll kind of talk about that a little bit when we're talking about tricks. And always check a lateral, I think, before you accept anything. And we talked about the ideal position on the AP view, and I think this is a good position on the lateral view. I do like to be a little bit plantar to midline. I think it, especially as I transition to weight bearing in a week or so after the surgery, because it really resists any potential motion or dorsal translation of that metatarsal head. Okay, so again, initial protocol, I kept it the same. I changed what I did, but in order for me to feel comfortable and know that if there was a failure, it wasn't a failure of the technique, I actually kept my protocol the same. They were still non-weight bearing through that forefoot for 6 weeks. I did allow them early range of motion. And at 6 weeks, even though there wasn't a ton of trabeculation, I knew that I would ultimately get it. And so I allowed weight, but again, aggressive range of motion. And we can start to see just a little bit of bone forming in that particular location. And this is her X-ray about 3 months later, and we can see that there's a solid column of bone. And so a leap of faith, yes, but at least for me, I have not had a patient not heal this osteotomy to date. That is not to say that there aren't instances of non-unions. I personally have not had one, and this first X-ray is very reassuring. So then I moved on to my second case. And this case was a patient who had a very small foot. And so the metatarsals were very short, somewhat of a moderate hallux valgus angle. And I took that on, and we can see my X-rays here. So let's critique this. Now, my second case. So I think I did a better job at that proximal screw starting point. And we can see here it's capturing that far cortex and then entering the metatarsal head laterally. And then we have our distal screw, but I have to say that I really kept feeling the outside of actually this is a male, of his skin, and really being concerned, will he feel that spike? Will he not feel that spike? And somewhat nervous about taking off that spike because I did not want to necessarily compromise I did not want to compromise this distal screw. And so admittedly, I couldn't feel it much externally, and so I left it. He actually went on to heal and not feel that at all. And there's bone bridging most of that gap. And so I think my critique for this is, again, I did a better job with the proximal screw placement, again, cortices, but I've learned a better way of dealing with that spike, and we'll talk about that as well. So my first handful of bunions were milder bunions. And again, I felt a little bit safer. But what did I learn doing a mild bunion? It's actually a little bit harder than doing a more significant bunion. But if you are going to use a tourniquet, and you don't necessarily need to use a tourniquet, but if you want to have a tourniquet, then one of the things I learned early on is do not use a calf tourniquet. You have to have a tourniquet that is higher, because if you have a calf tourniquet, when you have a smaller bunion, it's a more acute angle to capture it, because it's just not that displaced into the interspace, where you have just a wider trajectory for that guide wire. And if there's anything on the calf, like a tourniquet and a lot of dressings, you literally cannot swing your hand for just a more parallel, a throw that's more parallel to the long axis of the foot. And so I will not recommend a calf tourniquet. If your entry point, I noticed, is on sort of not the flare, but where there's that concavity in the metatarsal proximally, your screws will be distal. Your guide pin, like my first patient, will just slide along and it will be past that flare. So if you want to be at that flare, then you do not want your entry point for that guide pin to be distal to that flare, or you will have distal screws. That entry point, again, should be at the epiphyseal metaphyseal flare. I try to think of the epiphysis as, meaning that I'm really at that joint level. The other thing I noticed very early on is that if you have 50%, less than 50% translation, you really have that acute angle of trajectory. And so you need room to get close to that ankle. And so anything on your calf may impede you. And also, when you have a short metatarsal, that distal screw, it's not as though it's that distal, but you just don't have a lot of room to work. And it's not that you don't throw it, you have to throw it, but just sort of be aware that you'll be more distal than you would think. So at this point, I'm totally ready to jump right into this thing, with even more significant bunions. I love to run in the woods. And so I have a lot of video and of me, exercising in the woods. So here's the leap. Here's my big leap, right? This really more severe bunion. Now, this patient was definitely, it's more than a bunion. Obviously, she has a crossover deformity, and it was not the first large bunion that I did, right? But I have to say that I have been doing bunion correction with patients that are this severe using a minimally invasive technique. So that is her X-ray sort of overlaid. These are, this was actually her surgery. So we have our osteotomy, right, first step. We have our translation, second step. We have, we have screw fixation, the guide wire. The lateral view, again, I like to be a little bit plantar, just because I just feel better having them walk sooner. And I placed my screws, and then we have removal of the medial eminence and any redundant bone on that medial, on the medial aspect of the metatarsal. And this is her final product. I did correct that crossover to deformity since I was not doing all of the metatarsals. I did that with the mini open, and this is her, and this is her X-ray. Her clinical picture, So we started out here, and this is her foot 2 weeks after. Now, admittedly, I think she had more swelling than I would have expected, and probably because I had that part of the procedure was open, but it was her clinical picture, which, again, I think would have been worse had I not done that minimally invasively. So I'll get into some cases and some X-rays here, but as I started to move into larger bunions, these are things that I learned. The larger the IM angle, the easier the fixation. And I know it sounds counter, but it is. The smaller the angle, the helix valgus angle, and the smaller the correction, the more challenging just to put that first K-wire. You just need to know you have to have an acute angle. Also, the larger the IM angle, the more translation is possible because you have more room to move that metatarsal head over for correction, and the space in between. So I think it's the IM angle more so than the helix valgus angle that influences the extent of translation that you can have. And so what I learned, and I was burnt on, with getting less than ideal correction, is seeing a large helix valgus angle and not paying attention to metatarsus adductus with that second metatarsal swinging over, and the IM angle actually being remarkably small for the amount of deformity that's present at the joint. And so another thing to be aware of. Another pearl. So regardless of the IM angle that you're dealing with, if you have the chevron, a large chevron versus a small chevron, you may be able to translate that a little bit less. So a larger chevron osteotomy for the MIS will give you more stability. And early on, I did a large chevron because I loved having that piece of bone come, touching, and it made me feel more confident that they would heal. But it's then harder to move that metatarsal head 100%, sort of dragging that limb. And so I just perform a shorter chevron, but I still do believe in a chevron, because if you just have what I've noticed, a purely transverse osteotomy, yes, you get easier translation and it's good for large correction, but it's at the expense of stability. And so as you're translating over, and for those of you who've started doing it, I get this question all the time, like, oh my gosh, I translate over, but the head is dorsal, the head's plantar, I feel like I don't have control of it. And a lot of it has to do, I think, with it just being a straight cut. Now, maybe some people are good at that, but for me, and I think for most people that then try that, having a little bit of a plantar limb does keep it from just swinging dorsal. And so I recommend a shallow chevron if you're going to do a large amount of translation. The other pearl is that you want to, if you had to pick the metatarsal head translating one way or the other, you want to pick it slightly plantar as opposed to translating a dorsal, because as with any osteotomy, you're removing bone, and so you're technically shortening a little bit. Now, there are ways of mitigating that by changing the angle of the cut, not just transverse, but you raise your hand and you're slightly plantar, and so as you plantarly oriented, and so as you translate, it moves a little bit plantar and it gives you a little bit more length. But you don't want, especially in someone who has long second or third metatarsals, to have a dorsally displaced first metatarsal. And as things are shifting and as you're translating, be aware of a little bit of plantar translation versus a lot of plantar angulation, right? And so you want to be aware on the lateral view. And all of that to say, don't accept any AP position without also being satisfied with what you're seeing on the lateral, right? Because if you're less than ideal on an AP, okay, so say it's not 100% straight. You have a minuscule valgus, right? A small amount of recurrence is a cosmetic problem, but sesamoiditis or second metatarsal overload, sesamoiditis, if you really bring that down plantar, or if it's dorsal and now you have a second metatarsal that's taking that load, that ends up being a functional problem. So sesamoiditis or second metatarsal overload is a functional problem. A small amount of an incomplete correction is more of a cosmetic problem. And I think we know this from open procedures already, right? So I'm not telling you anything you don't already know, but you then need to assess, the potential for them having an issue on the lateral view. And so I would redo any reduction and repin any first metatarsal if that head is significantly dorsally translated, and I would definitely redo it if it's dorsally angulated. I would pull those pins out, and then retranslate that metatarsal head. So hone your skills, right? I mean, there are ways, there are national courses, there are regional courses, and there are cadaver trucks that will come into your area. There's one-on-one mentorship. I've definitely spoken to people before they're first. We've done a Zoom kind of talking things over. And so there are a lot of resources, but you do want to hone your skills, because here is kind of what's possible. So these are all of my patients. So clinical pictures, one of my patients, now I actually discouraged bilateral surgery, but she did wear me down, and I performed both surgeries on the same day. And these are clinical pictures before correction, and these are her clinical pictures after correction. This is about 3 months after her hallux valgus correction. So these are her x-rays. And I would say that she had a mild amount of arthritis on the left side, but even with that, able to get some good correction for her. Okay, and so here's another patient of mine. She has less deformity than that first patient, and so she required less translation. And this is what her x-rays looked like 2 weeks post-op. And literally just took out her stitches. What I like about this is that, she has good alignment. I can even see some of the veins in her foot. She does not have a whole lot of swelling. And again, most patients, if they take oxycodone through the weekend, that's actually uncommon. Most patients are fine on just Tylenol. Here's yet another young patient of mine who really was tortured in shoes. I will show you her x-rays in a second because her x-rays really don't reflect what we're seeing clinically. So, I mean, I would say that that's a hallux valgus that's worth correcting. And you can see here that she has a lot of pressure in her shoe, right? I mean, there's clearly pressure against that skin. But this is x-ray. I mean, it's really not that impressive. But obviously she has an issue. And so I did her hallux valgus correction. She had a very large dorsal medial eminence that I removed with a wedge burr. And I think that because of that, she had a lot of irritation, but these are her x-rays, her AP and her lateral. So I'll move that down a little bit. And she had, I thought, good alignment on all of them. Another patient who, at this point, I was getting patients back to walking fairly quickly. This is her foot 2 weeks after surgery. You can see there's still stitches in place. And she had some bruising, some ecchymosis, but overall, I think her swelling is not that bad. So what I noticed in my practice is that in performing the procedure in this particular way, the number one thing almost across the board is decreased narcotic use. Patient, I have a Tylenol regimen. You take 1,000 milligrams every 8 hours. I will allow 200 or 400 milligrams of ibuprofen every 8 hours, and I stagger that. So every 4 hours, they're taking either 1,000 milligrams of Tylenol or 200 or 400 milligrams of ibuprofen, and then we'll dose oxycodone on top of that. I've had patients tell me they took none. I had one patient told me she took a third of an oxycodone. I'm not even sure how that was possible. Or they just take something through the weekend, and more so because they're afraid of having pain. So that decreased narcotic use is fairly uniform, fairly consistent across the board with all patients. Notice also a significantly less swelling than I ever saw when I did open bunion correction. Patients also had much less scarring, right? You don't have large incisions. We're not stripping a lot of tissue to put in retractors. And so any scarring that they have is really at the level of that incision. And that is something that we really work out a lot with therapy and with massage. And with less scarring, and because it's an extra-articular osteotomy, they're able to move, and so patients have great range of motion. And with that, earlier for my patients, I've seen them running as close as 3 months out from surgery. But I really push that early motion. They're starting to move their toes almost immediately after surgery. And here's another patient who is this was about 5 days out from surgery. And that was that same patient, opposite side, actually. And here she is now about 3 months afterward. Another patient, again, much less swelling, less scarring. This patient is approximately about 6 weeks. And you can see all of her calluses are essentially falling off. And again, here we are with what the incision then looks like later on. The swelling, the difference in swelling from open procedures is huge. This patient is 3 months out. I know this is the operative side because it's still a little bit rubrous in color, but you can see her vein pattern. If this did not look post-operative for the mild discoloration, you would think that she had no swelling at all. It will be the swelling has not been an issue. And with that, patients have been able to get back into shoes much more quickly. Again, much less swelling. That's my one patient with that open procedure. So now we get back to her. And this is close to 3 months after her surgery. And again, much less swelling. Motion, right? As we do early motion, have your patients just start moving. So this is about 6 weeks, and that's how much motion this patient achieved. And about 3 months afterward, many patients who have near full motion of their joint. What this means is that they can then get back into activities that require a lot of extension of that hallux. So things like running, yoga, where they're doing lunging, the motion. I think is really key to patients also feeling that they have a good outcome. Okay, so here are some tips.
Every once in a while,
Actually, I'll move over to this one here first.
every once in a while, someone, I get a lot of questions about where to stand, and I know that some people, say you can stand on the side that you're dominant. Some people may switch back and forth. I think honestly, see what really makes you comfortable. I think if you're right-handed, and if you stand on the right side of the bed, I think early on, especially, there can be some confusion as you're rotating your hand, but you can certainly stand at the edge of the bed and work in this particular way, or even more to the side if you feel that that really makes you most comfortable. Obviously, on the left side, if you feel more comfortable as a right-hand surgeon standing on the right side, then do it. I think doing it open a little bit first, as I have discussed in the past, making a bigger incision and using the burr would be helpful for learning the hand motions. But I think while you're doing that, just really see where you feel comfortable and where you feel in control, if that's the best. Or it's mentioned that your cut is too distal or too proximal. And obviously you're going to check radiographically, but I do think that, just feeling the anatomy is really helpful. So if you drop off of the flare here of that medial eminence and you're at the metaphyseal junction, it tends to be right here. And I think you can have that as a starting point and then correlate that radiographically. But for the most part, that ends up being just the spot to do the osteotomy. And I think that's helpful if you're wondering if you're too far distal or proximal with your starting point.
And so then after you decide where you're going to make your osteotomy cut, you verify that radiographically. The other thing that I found is helpful, especially starting out early, I mentioned it briefly on that first video. If you're worried a little bit about going from doing all of your surgeries open to then doing this surgery through a poke hole incision, I think a good way to get comfortable is to just start with a mini open. And what I recommend then is, instead of doing your bone cut with a sagittal saw, even if you're doing a minimally open incision or even a fully open incision, start using the burr. Start using the burr as your cutting tool and practice that hand motion. And you can actually then see what you're doing. You can see what the burr is doing. And it gives you a feel for it, and you get a little bit more facile at it. And then you can then make smaller and smaller incisions, because you already have in your mind's eye what your hand and what the burr is doing while you're not even looking at the bone. And I think that's a great way to kind of start out. But another way too, to help when you start doing your first surgeries, is really to be able to visualize what's going on, or at least the bone internally, when you're only looking at the skin. And so this is something that I recommend.
That I think is helpful when starting out is they're really outlining the metatarsal, right? Because you're trying to visualize what's going on inside, but all you're looking at is skin. And this comes in handy when you're looking at throwing your guide wires. When you're throwing your guide wires for screw placement. Are you going to be too plantar in it with your trajectory? Are you going to be too dorsal with your trajectory? I think that knowing what that longitudinal axis is along your metatarsal helps you, so that you actually do less thoracoscopy and you have less throws. So a lot of times, especially starting out, I encourage one to outline, and I a lot of times do it myself if I'm not using a solo guide.
Okay. And
doing the osteotomy, when I hold the grade 2, I extend it a little bit so that the EHL is relaxed as opposed to being taut when I come out of the top. And that, I think, makes me feel better that there's little or no injury that will ever happen to it, because it's never going to be stretched or strained over the burr.
right. And so what I'm saying there is that as I'm doing my osteotomy, and for people who do chilectomies minimally invasively, this holds true as well. As I'm making my cut and I'm doing that dorsal limb, I extend the first MTP joint, and that way the EHL is relaxed. It's not taut in any way. So even though with that low RPM, there's very little chance of injuring the soft tissues, you really don't want to do something that may then put strain of the tendon over that burr. You know, you want to be safe at all times. And so that is one thing that I do. And when I do my plantar limb, I actually then flex that first MTP joint so that all of this, the plantar structures are also somewhat relaxed.
And so another trick that I learned over time to minimize throws is that if I realize I need to change it on the AP, change the angle, right, where it's going to come out of that far cortex, but I lighten the trajectory on the lateral, then I will oftentimes just almost draw a line along this wire so that I can mimic that when I change my throw. So at least I know where I am, dorsal plantar, and I know that I would like it. Again, it minimizes the throws and the amount of space. And so another trick, I know that the teaching is, and it's sound teaching, and it makes all the sense in the world, to pack your wires first. I initially translate, so I know how much translation I'm going to get. So I know where I want to come out in that far cortex. It's not an issue with a large angle. With a large angle, fires them first, but a small angle, you really may not capture it. And so I like with my smaller bunions to know where that translation is maximized, and then I kind of tailor where I'm coming out. But with all bunions, right, the maneuver is to do that rotation, right, that supination of it to get to the sesamoid aligned. Of course, unless you're arthritic, and then you're not really the sesamoid to save your life, so don't kill yourself. But then with that, you then do that translation over with the capital fragment in a more neutral position.
Okay, so what I was saying there, and I realized I should have prefaced that, is that, you know, in that fourth step, you know, you throw your wires, you do your osteotomy translation, and then you capture that metatarsal head. And for the people who find that a little bit difficult or maybe counterintuitive, I would say, you know, again, do what makes you comfortable. For me, if it's a large angle, I have a lot of room where I'm translating that metatarsal. Absolutely, you know, you're going to capture it once you have that wire through. But when you have small angle and it's like, you know, 50% translation, and you're coming in really acutely, then you can't really exit that distal lateral metatarsal with that guide wire, you know, just too proximally, you're going to miss that head. And so for a smaller bunion, I actually translate it first and do my correction first. And at least to be able to see, okay, it's going over this far. Okay, I really am going to have this type of an angle, and I throw my wire and then re-reduce it and capture it. And that's all I'm saying, in addition to showing the motion for reduction of that capital fragment. So other tips, I'm sure there are no more videos, but other tips, you know, you have to get that medial eminence resected, okay? I personally, over time, realized that it's better to do all your bony resections before you do any Aiken osteotomy, because then I don't really want to manipulate my proximal phalanx a lot after doing the Aiken. I just personally don't like doing it. And so if you have a bunion with a lot of translation, you have a big medial spike here, then you can resect that through the same incision that you used for your distal screw, or if you're using the solo guide, there is actually a tool for this, but you then use your 2mm cutting burr, and you literally just cut that spike off. And you can see here that that's gone. And so that removes that prominence. So had I known that with my second patient, you would not have had that spike, although clinically no one could feel it at the level of the skin, but that is how you get rid of that spike. And then you use the wedge burr to remove the medial eminence. There are times though, when if someone has, right, I really don't feel I can get that angle. at all. Proximally, in a pinch, and actually more often than in a pinch, I will do the resection from a distal position, especially if I'm doing an Aiken. So I'll have my incision for the Aiken, and then I use pass the elevator under the capsule, and I take an X-ray to make sure I'm against bone, because you don't want to be above the capsule at all for any of this. Obviously, you don't want to injure the dorsomedial nerve. But ensuring that you're against skin, I have actually done that resection of the medial eminence from distal to proximal, just sweeping along. Especially if someone has like a large projection for their medial eminence, you can enter inside and then do an inside to out resection, and that actually works really nicely. So other things, as you're starting to translate and do bigger angles, be aware when you're doing your translation that you're not increasing your distal metatarsal articular angle, right? So you can see in this first X-ray here that the metatarsal is tilting and actually pointing in valgus, even though obviously it's translated over and this person will have a much more narrow foot. In this situation, the foot will be narrower, but they will still have a valgus alignment to that first MTP joint. And so that's why that maneuver is important, where you're doing that supination and adduction as you're translating that metatarsal over, so that you're not just pushing it over and tilting it, and then you're looking at the two and you're like, gosh, it's over a whole lot. Why does it still look as though it's in valgus? And if you look at it clinically and you think that, then just pay attention and see, okay, well, what's the orientation of my joint, right? And you can see here, the orientation is actually probably a little bit further than neutral. But here, this metatarsal has a good alignment for the joint. That articular angle is good. And so this toe is straight. The other thing I wanted to point out on this X-ray is I judge my reduction based on congruency at the lateral cortex. I don't look at congruency medially. I mean, someone can have a big medial eminence. Some people, may have spurring, whatever it is. I judge it on this lateral view. If this lines up, that's really the maximum reduction that I'm going to get, and it usually correlates with good alignment overall. I'm going to show this one and just talk about this briefly, and I realize I'm going to run out of time, and so I won't go over the solo guide. I think we can do that another time. But here's something I mentioned before, that your IM angle being small, even though there is a valgus deformity and a prominent medial eminence and a painful bunion, does make translation difficult, right? Where am I going to move this head? There isn't that much room there. You're able to move it over, but in a situation like this, remember, the Aiken can be your friend. Every once in a while, someone will say, well, if you're correcting a bunion, well, you shouldn't need an Aiken. And I just don't subscribe to that. Because here's a situation where someone has a bunion, they have an angle, hallux valgus angle, but they really don't have a large IM angle. And so you're going to move that over. So there's no prominence in medial eminence. But in this situation, an Aiken will serve you well, even after you've maximally rotated and you feel like the sesamoids are well aligned. And so I'll just briefly show the Aiken osteotomy. We all do this open. It's probably easy to figure out how to do it minimally invasively. But again, you make a small stab incision. You do that medial closing wedge using a 2 by 12 millimeter burr. Try to keep that lateral cortex intact. Sometimes not always possible as you move it over. But you hold it reduced, fire your pin, and you place a 3/0 screw. And I was going to just go over a little bit of the solo guide, but I think that we're probably out of time. We probably have a lot of questions that I need to get through in a very short time. So Jen, I'll let you take over.
Yes, thank you. That was a great presentation. So we actually had two come through. I'm going to combine them a little bit, but one individual's been doing Mika for 3 years, and they've been putting them in bunion dressings for 6 weeks post-op. They're just curious if that can be shortened, what your dressing protocol is, and then in addition to that, what about surgical shoe / boot, and for how long?
Okay, so I do believe in the bunion dressing. I wanted to see if I had a picture at the end here, and I think I may have passed it. I do think, let me stop sharing my screen here for a second. I will do a bunion dressing. I mentioned that I changed my protocol over time. I went from 6 weeks of no weight bearing to 5 weeks of no weight bearing to 4 to 3 to 2 to 1, with patients doing very well. And so I especially with that screw construct, can't get them walking. I have them heel weight bear that weekend because obviously they're going to have a little bit of pain. And at the next week, if they're feeling comfortable and want to, I allow them to bear flat foot weight. And I do a bunion dressing, and I do a bunion dressing for about 6 weeks. I have a technique that I use where it pulls the metatarsal over a little bit. It might be good. Actually, a video of just the dressing, I think, might be helpful. Maybe I'll create that and be willing to share that. And I change that every couple of weeks. But for patients who, especially if they come into town and then they're leaving, and or they're not going to be around for me to do a bunion dressing, I have gotten a bunion sleeve that will do a little bit of compression. They slide it over, it does a little bit of compression, it holds them over and does a little bit of padding. And that too can be a bunion dressing, even though it's something that's sort of off the shelf. I think that is important in the first 6 weeks.
Perfect. So let's see. Is there a place for no fixation of chevron or an Aiken just to control with dressings or a K-wire?
Well, for the distal metatarsal osteotomies, yes, 100%. But I don't know that there is a role for no fixation with that Aiken unless you're having somebody not put weight on it at all. But think about your population, right? You're going to have your older people that have poor balance, right? Things always happen. Someone comes in, you're like, doctor, what did the x-ray look like? And you're like, why, did something happen? Yes, I fell or I put that weight on it. Like something will happen and it will move. And if you're going to go through the trouble of doing that osteotomy for correction, then why not hold it in the alignment that it is in for that correction and allow it to heal there, right? And the purpose of hardware, obviously, is not to let the bone heal. The bone heals, but the purpose of the hardware is to hold the osteotomy, to hold the bone in the alignment you want it to be in so that it heals right there and that patient has a good outcome. You can do a K-wire, and in the first couple of iterations of MIS, and we're like in our fourth iteration, and this has worked well because people have tried it in the past decades ago and there are issues with it where it failed. And one thing was actually just K-wire fixation. There are potential issues with infection, right? Think about your second metatarsal, think about your hammer toe, your claw toe. How many times have you pulled a pin, right? Because, bacteria is tracked along it. How many times did that pin start to back out? For a bone as large as that first metatarsal and the forces that can come through it, I would not rely on just that, but it has been done and has not worked.
Perfect. So we have another one. Any tenotomies for patients with large hallux valgus, or do you find in your experience that bony correction is enough?
A tenotomy as in, or an adductor release. I've done 3 since 2017. I think I felt that I shouldn't have done them after I did, but felt that, man, this angle is so huge. And, and I'm translating them over and they don't seem to be moving very much. And so I've done it. And here's another thing potentially worth discussing at another time for another talk. What about those patients with a large angle and a tight EHL, right? Which is something to think about. And I wouldn't do a tenotomy on the EHL, obviously, but a tight EHL, and that is kind of holding them over, and a joint that is not passively reducible. So if someone has a passively reducible first MTP joint, like I look at the hallux, Michael, that looks fairly severe, but I can now reduce it straight and give them a straight toe with my hand. Then when I'm giving them a straight toe with my hand, then it usually means that there is enough, there isn't that much stiffness of the soft tissues for you to then require a release. And in fact, none of those patients have required releases. The ones where I thought, man, this kind of looks less than ideal, and and maybe I should do a release, are the patients who you can't really fully reduce them. And I guess that was always the deciding factor, even with an open procedure, right? When do you do that release? You know, you manipulate them. Can you bring them into varus? Can you bring them fully straight? Do you do that release? One of the things that I have done over time, especially if they have a longer first metatarsal, is then I would actually, through my osteotomy, just maybe do, put in a 3 millimeter burr and take away like just an extra millimeter of bone, which effectively lengthens that first, that EHL. But I think you kind of think about like what's holding you up. I wouldn't do a tenotomy of the EHL. Obviously, I'm sure we're talking about an adductor release. But I've done it very, very few times, very few times.
Perfect. And I think, you know, we had another question as it pertains to how often you do a PERC or open adductor release, since we're on the topic.
Yeah, honestly, I've done 3. I've regretted doing each one. You know, you're motivated to do it, right? Because you're thinking, okay, you know, in those cases, it's not moving over. And then you're like, oh, should I have done a lapidus? But I've been in situations doing a lapidus where I've had this same feeling. And I really think that it boils down to whether it's reducible or not, and maybe planning for that. But I've done about 3, and I did them open, and you know, just to get them over a little bit more, and for better correction.
Perfect. So it looks like we have one more question, just enough time. So how much surgical time do you need, and have you gotten faster?
I have gotten faster, you know, and especially I think, you know, you need to know how to throw the wires with you know, freehand, right? And then there's the solo guide that can help. And for some people, the solo really makes it better or quicker. But it has definitely improved over time. I think, you know, tricks such as, you know, if you like your lateral, kind of, you know, drawing that line on the skin so that, you know, if you're repositioning on the AP view, you know where you are, knowing where the metatarsal is, just having an idea visually has really helped cut down on time and cut down on the number of x-rays, you know, and the fluoroscopy that is used.
Awesome. All right, one last one. Are you using a 4-3 screw construct? Do you ever use a 4-4 screw construct?
I've used a 4-4. I used one the other day. This person, it was just a long metatarsal. And for whatever reason, I just felt strongly I needed to, I just needed 2 4-0 screws. Nothing wrong with that at all. Nothing wrong with that at all. You know, if you have a smaller bone, then you just don't have the real estate for it. But truly nothing wrong with that. I have not done 2 3s, but I have done 2 4s just once, but usually a 4-0 and a 3-0 construct.
Awesome. Well, thank you, Dr. Mesnier. We are all out of questions and time for tonight, but thank you everybody for joined. We're really excited. It's recorded. I'll try to get it up onto YouTube and our Stryker.com site as soon as possible. And I hope you have a great night, and we'll see you soon.